everyone. We're ready for another club webinar. We're already at 33. I feel like I say that all the time, each time saying the same thing. Maybe I should shake it up and do it a little different once in a while. The club webinars, again, are a little different than our student webinars that we do. We kind of interchange those back and forth. With the club webinars, those are topics that you send in, and then we answer those questions, kind of like our Q&A webinar, but it's just me, one person answering usually just one question, taking our hour. So a question definitely came in to the club this week, and the particular person was having problems coding a secondary diagnosis or understanding how secondary diagnosis is dealt with the disease process. So I'll show you the question that she had asked, and I answered it on the forum, but I thought, you know what, she's probably not the only one that struggles with this. So let's clarify the coding that surrounds a secondary diagnosis. And I like to think of there being two types of secondary diagnoses. So we'll talk about them and I'll clarify, because what she was misunderstanding and I think was getting confused with the other type of secondary diagnosis. And it's almost like semantics, except for they really do mean two separate things. So that really isn't semantics. Semantics mean one word, like tomato, tomato. Secondary diagnosis and secondary diagnosis when you're dealing with ICD is not the same thing, actually. The question came in and says, I'm having trouble understanding what to code when a diagnosis or condition is secondary to something else. Okay, so let me explain just briefly before we get into the next slide what she was asking more in depth, because this is the actual question that came in, and then she kind of gave an example, and then we went through and broke it up. So secondary, in the aspect that she was needing, was a condition that causes another condition. Okay, so think of it more in terms of disease process, and I've got a few examples to think this through, versus something that is a secondary diagnosis, meaning I have one diagnosis and I also have a second diagnosis. So an example of that would be, I have diabetes, but I also have COPD. Well, they're not related. I have two diagnoses. And if you're going in, say, into the hospital and you're being treated for COPD, COPD is the principal diagnosis. Why are you being admitted for the COPD? I happen to have diabetes, and that's going to be pertinent to my care. So that would be a secondary diagnosis, right? Whereas what she meant by a secondary diagnosis condition is that a person has diabetes because she has pancreatic cancer. Okay, so she wouldn't have diabetes if she hadn't gotten pancreatic cancer. So it's a secondary condition due to the first. I like to think of it as it tripped the body into something else. Okay, so let's break this down a little bit. The basic terminology. Okay, and hold on just a second. That feels like that's not the right slide. It's not. Yeah, I guess it is. All right, basic terminology. So we don't want to confuse these with other types of conditions, like, man, I thought I had it. Sorry that that's messing with my brain, but I thought I had another slide in between there. Combination codes. Okay, with combination codes, you have a secondary code that explains more in depth what's going on. And these I pulled straight from the ICD-10 guidelines, all right? That's why it says 9 combination code. You're literally going to go there in your ICD-10 coding guidelines, look up combination codes, and I pulled it from that. Now, I also put that in the resource slide. So it's a combination, and it's a single code used to tell two diagnoses. Thus, diabetes does this a lot, right? You have diabetes like E11.4, and then whatever the 0.4 condition is, you may be asked to go clarify that with another diagnosis code, right? Think of when a person has, they have chronic kidney disease and they have hypertension. Okay, you will code not your regular I-10 code for hypertension. It's a different code, and then it tells you, in addition, to code what stage of CKD they have, like in 18.3. Okay, so those are that's kind of how a combination code. You may have one code that tells the story of two codes. You could have, like it's saying in this bullet, a diagnosis, and you have an associated secondary process that's a manifestation. So you have an etiology and a manifestation. Now, if you're not familiar with the terms etiology and manifestation, we have a video on that. So you can go into the club and you can just put in etiology. It might even be on the YouTube channel. I'm not sure if that's divided up, but go in to our YouTube channel, Medical Coding Cert, click on the little looking glass and put in etiology, hit that, and then any of the videos that we've done that talks about etiology, those will pop up for the last 8 years. Now, but the one that I remember us doing was on etiology and manifestation, and then we talked about what that actually is. So I know it's going to be in the club. Not sure if it's on YouTube. A diagnosis with an associated complication. And again, so that's what a combination codes, and those are classified. They'll have secondary codes that are put in there, right? That's not what she was talking about, right? Now, don't confuse it either with the guidelines that tell you that you need to use an additional code to code for BMI, coma scale, or the NIHSS, and that is whenever you're going to add those Z codes, Z55 through Z65. And I went ahead and just put that in there just in case you weren't familiar with that code range, that these are potential health hazards and specific socioeconomic and psychological circumstances, right? So these are secondary codes that tell more of the story. And so with a BMI, you cannot code for a BMI unless the doctor states that the patient has obesity or is malnutrition, under their BMI is too low. Okay, just because there is a BMI of 45, okay, that doesn't mean that you can send that BMI, code for that. It has to have a diagnosis somewhere of obesity or morbid obesity, or that, like a malnutrition type code. Same thing with the coma scale. You can go ahead and tell the rest of the coma scale at what level the coma scale is with that secondary code. It's almost like painting a picture and then putting the highlights in. Let's explain it a little bit more. Now, does that mean that every time you code for obesity or morbid obesity that you have to have a BMI code? No, because you may not have the BMI listed. What it's telling you is that if you have a BMI, and they're usually documented by the clinician right there by the vital signs, that's where you find them often. So you have your BMI listed. You don't want to code the BMI for 50 and then not have anywhere else that it states that the patient has diabetes. That is it's a secondary code that has to have another code to be able to launch off of. See how my brain works? And in addition, Z codes. Z codes are often used as secondary codes. We're not talking about those. What you are telling with Z codes is give us more information as to why the patient's being seen. And you could have a principal diagnosis, or you could have a first listed diagnosis. Now, principal diagnosis, first listed diagnosis, the difference in that terminology is one is for inpatient and one is for outpatient. Okay, same thing with principal, first listed, or secondary, depending on what's happening with the patient. So Z codes, a little more information. So what do they look like? Here are possible Z codes that you'll see sometimes. Now, why would it be pertinent to put Z59.0? If the patient, is the patient being seen by the provider because they're homeless? No, they're not. They're being seen by the provider because maybe they have got brought into the ER with hypothermia and possibly, and frostbite on their toes. Because why? They're a Z59.0. Okay, they weren't put into the ER or admitted because they were homeless. We need more information to explain the story, right? Same thing with inadequate housing and extreme poverty. These are codes that Z codes explain. Why is that patient being seen? Oh, because they have diabetes. Okay, what's the problem? Well, they're a Z59.5, extreme poverty, and they can't afford their insulin. And so, therefore, or even get a ride to the pharmacy or whatever, so that explains the situation a little bit better, why they are having problems with their diabetes. Okay, so what I would urge you to do is, if you're new to Z codes, go ahead and look at the Z codes. Look at them in the index, but also look at them in the tabular, right? Because there's specific guidelines that surround them above and beyond what we're talking about. Okay, so don't confuse those, because that's not what we're talking about here. This isn't the disease process. This is a secondary code to explain the situation that's happening. It's the highlights to the story or the picture. There's another reason for secondary codes that pop up for sequencing severe sepsis. Now, we've done a lot of training on sepsis coding and severe sepsis coding. Ultimately, it breaks it down. You can have sepsis, but when it turns into severe sepsis, you start having dysfunction and of organ systems shutting down. And the code that you want to pay attention to is R65.2. Okay, so you could have an underlying systemic infection, and it has tripped into severe sepsis. And then you're going to show that the R65.2 is going to be assigned as a secondary diagnosis, right? But that isn't really what we're talking about per se in the scenario that she came up with. This is telling more of the story. We have a systemic infection, and that means an infection throughout the body. You can be septic, you can have sepsis, but when you trip into severe sepsis, then again we start having organs shut down, organ systems, and often you're going to be using two codes, a secondary code, to explain that. All right. So now that I've kind of explained what is not the secondary diagnosis that she was referring to, now you've got that pictured in your mind. Every time you hear the term secondary diagnosis, you need to ask yourself, is this just an additional code we need to explain what's happening to the patient? Paint that picture. because there's one code doesn't explain it. We need two codes to do that. Or is this a secondary condition that I like to think of as a condition that trips the body into another condition? Okay, so these perfect example. And the reason I put testing here is because I wanted you to know that these are things that they actually will test you on. That's why it's important that you understand. Now, they're going to test you on secondary diagnoses and those Z codes, things like that. But I don't want you to get them confused with how secondary diagnosis like a Z code is different from a secondary diabetes mellitus. Okay. So let's explain that, because anything that you want to explain in coding can usually be taught through diabetes. And by the time you get through your courses and stuff, you're going to know more about diabetes than you ever thought that you would. Because again, it's such the disease itself and the disease process has so much minutia to it that it has lots and lots of guidelines. It's the perfect example for secondary diabetes mellitus. Now, notice I didn't say it's a secondary diagnosis. This is a condition that's a secondary condition. And in this format, what it means is the patient has diabetes because something else happened. The codes that you want to look at, and these are codes that you probably are not going to use that often, but they will definitely show up in your multiple choices. Okay, let's say one of the formats or one of the scenarios that they always test you on is a guideline where they don't put in the documentation what type of diabetes that the patient has. And we know our guideline tells us, the guidelines tell us to default to type 2, because like 98% of all diabetics are really actually type 2. But in your multiple choices, it's going to say it's an E08, an E09, maybe an E13, and then it'll say, or get this, it'll say it's a E13, give you a choice between E11 or E10. So E11, E11 is type 2 diabetes. E10 is type 1 diabetes. Okay. And we know the guideline says we got to do type 2, but they're going to put in E13. Why? Because it's other diabetes. And so you're going to think, well, they didn't say. They didn't say if it was type 1 or type 2, so it must be other, right? So that would be a classic new coder mistake that doesn't understand the guideline. When in actuality, E13 is other specified diabetes, identifying complications, manifestations associated with secondary diabetes mellitus. So they would not have had diabetes unless this happened. Same thing with E08. E08 is your diabetes, and it's due to, classic, due to, pay attention to that, underlying condition. All right, so some type of condition caused the body to become diabetic. Right? It's not a secondary diagnosis. It's a secondary, diabetes is secondary to something else. And then we have E09, drug or chemical induced diabetes mellitus. So let's say you the patient has an overdose on Tylenol, which actually is extremely hard on the liver. It tears up the liver, and it also starts affecting the pancreas, and therefore it trips them into diabetes because the pancreas and the liver can't keep up. And so they're a secondary diabetic. So they would not be a diabetic unless something happened to the pancreas. Now, drug or chemical, meaning there was a drug, they took a drug or some type of chemical, tripped the body into going haywire, and then it induced diabetes. E08 would be a pancreatic tumor, turn the patient into a diabetic. Now, there is a type of diabetes that you can get that's a temporary diabetes, and most of these are temporary. E11 and E10, first and type 1 and type 2 usually are not. Once a person gets diabetes, they're not going to stop being a diabetic. Can they stop using medication? Maybe. A type 2, maybe, unless they've had some type of, if they're type 2 diabetic and they have some type of gastric surgery, that'll stop diabetes. But that's another whole lecture, which we've already done before. But again, these are sometimes thought of as temporary diabetes. So if the underlying condition is resolved, the patient would no longer be a diabetic. They'd no longer be an E08. Okay, so let's say the patient has a mass on their pancreas and their pancreas is inflamed and irritated, or they get pancreatitis and then their sugars go crazy and they are treated, their body becomes diabetic. And you have to understand the definition of what diabetes is. And then once the irritation goes down, the pancreatitis is treated, the blood sugars normal out, they become normalized. And therefore, they're no longer an E08. The condition can go away. Maybe they have a mass on their pancreas and it's removed. They have a partial pancreectomy. Okay. And then, so the trauma to the pancreas due to the surgery is going to trip that person into a state of diabetes that normally would not have been there. So they treat you just like you're a diabetic. You may get oral medication. You may even have to take insulin, but it's a temporary thing. Sometimes when they do heart procedures to a patient, a friend of ours had a valve replaced. And so when that valve replaced, when they wake up from the operation, their body is kind of in a suspended state of diabetes. Now, there's a much better way to explain this, but it's a temporary diabetes. So what they'll do is, the protocol for a lot of hospitals is, after they do specific heart surgeries, is they'll put the patient on a diabetic diet, right, while they're recovering. Okay. And then when the blood sugars normal out, the body adjusts to the trauma or whatever, usually it's trauma. Whenever you mess with the heart, you have to remember the heart is chemical, it's electrical, and it's a muscle. So again, all three of those things, and you mess with the heart, you're going to mess up the chemical balance, right? And that's what diabetes is. It's a chemical imbalance in the body that makes you either not able to absorb the sugar, to break down the sugars, or one way or another, you can't, the sugars don't work. And again, we've done lots of education on diabetes. Now, E09 already said that's a chemical or drug induced type of diabetes. And then the E13 is other. And you understand that other means that it is defined, we just don't have a code for that yet. Okay, so other. But to be an E13, we have to remember it's a secondary diabetes. It's not diabetes other, because that would be an E11.8, I think, is other, right? Or E10.8. Usually 0.8 tends to be other. Sometimes it's unspecified, but and sometimes 0.9, but usually 0.9 is unspecified and 0.8 tends to be other. Unspecified means we don't have documentation to tell us. So therefore, if we have documentation that the patient is diabetic, but we don't know if they're type 1, type 2, or any other type of diabetes, then it's E11.9 because it's unspecified. Right? And we default to type 2. All right, I think I explained that enough. Some of the second reasons the body could be tripped into one of these types of diabetes in the guidelines, this is straight from your guidelines, is that you could have had, you could have cystic fibrosis. Of course, I already mentioned the cancer, pancreatectomy, and of course some type of a poisoning and stuff. But there are a few other conditions, but those are the main ones that the most common, and that's why they're mentioned. For testing purposes, also, when you look at the sequencing for secondary diabetes, make sure that you look at the tabular instructions. So when you, it's kind of easy to just remember E08, E09, and E13 are not, are secondary diabetes, okay, caused by something else. But when you find that in the index and they say, okay, well, this is an E08. Okay, so you decide it's an E08. When you get into the tabular at E08, you make sure that you look all around right at the beginning of the E08s and see if there's any pertinent guidelines specific to E08, right? Very important that you do that. In fact, it would behoove you to do that tonight. Open up your tabular in your ICD manual, go to E08 and just read around E08. Familiarize yourself with the options. Maybe you need to make yourself a little note. Maybe E09, you need to say, you need to highlight drug induced or poisoning, chemical. And E13, you write other real big out to the side so that you know that it's that, that catch-all. So let's give you a little bit more specificity on a pancreatectomy, because they go into that a little more in depth with a guideline. And it says secondary diabetes mellitus due to pancreatectomy. In other words, if you get a pancreatectomy, you're going to get diabetes. So it tells you, just pay attention, that if you have lack of insulin due to surgical removal of the pancreas, because that's what's going to happen. Your body's not going to, your pancreas, one of the functions of it is to produce insulin. If you don't have insulin, your body can't break down the sugar. And so therefore you have too much sugar in your body, which makes you diabetic. It tells you, it says, hey, heads up, you're going to also assign the code E89.1, which is post-procedural hypoinsulinemia. What does that mean? Because we had a procedure, a pancreatectomy, we don't have enough insulin, hypoinsulinemia. Okay, so E89.1 is probably going to be in that heads up around your codes for E08. It's going to say, hey, by the way, do you need to code E89.1 in addition? If you go and look at E89.1, it's going to say, hey, by the way, do you need to code E08? You know, don't forget to code E08. Then it tells you, assign a code from category E13 and code for subcategory Z90.41, acquired absence of pancreas, as additional codes. Okay, now, it's telling you that if our patient has their pancreas removed, then we can't just get by with coding them as a diabetic. No, there's a lot of codes involved here. So they're saying, actually get a code from E13, not E08, like I said before, because it says other. So when you go look at E13, it probably has a note there that says pancreatectomy, okay? Then you know that if a patient has a pancreatectomy, that, and they're not going to be producing insulin, so they're an E89.1, and they're going to be a Z90.41. Why? The Z code is actually a secondary code to explain why their body's not producing insulin, because they had a pancreatectomy. See how? That's a secondary code, a Z code explaining the story, whereas secondary diabetes is actually a condition. It's a diagnosis in and of itself. It's not a Secondary diagnosis, it's a condition, secondary diabetes. All right. See, I told you, you can explain everything you need to with diabetes. I see the questions popping up over here, and I've got a little place at the end where I'm going to answer questions, so I won't forget them. Keep letting us know what they are, okay? All right, so let's move on. More for testing. Secondary diabetes due to drugs. It says, oh, heads up. And if it's due to drugs, that means that it's also could be a poisoning, right? We're looking at the not the E08, but the E09, the E09 codes. It says if you have secondary diabetes because of an adverse effect that was correctly administered medication, poisoning, or sequela of a poisoning, it says, hey, go look at the guideline 1C19E because there are specific things you need to code for adverse effect and poisoning. And then it says also go pay attention to 1C20 for external cause code reporting. Right now, I didn't pull those guidelines because quite honestly, you can go do that yourself. Okay. But it's saying, oh, heads up. Now we already had a heads up for the E08, and then I said that pancreectomy was an E13, it said in that guideline. And now they're saying an E09. If you got a secondary diabetes due to drugs, pay attention to these other guidelines that are applicable. It honestly, whenever you're being tested on the guidelines. And as long as you understand this and you practice this and give yourself scenarios, what would I code in a situation like this, then makes sense. Moving on. So we talked about diabetes, and like I said, I can just about guarantee that you'll probably see, at least in the options, a code of E08, E09, or E13 in your choices for a type of diabetes, because it makes easy test questions. Let's talk about another condition called secondary hypertension. Now, this is not a code, this is a condition, secondary hypertension, just like secondary diabetes. You wouldn't have hypertension if something else didn't happen, an underlying condition. So whenever you have secondary hypertension, first of all, it's telling you you're going to use two codes. Secondary hypertension means you're going to have one code and a secondary code. Don't get those confused because it's two separate things. Okay, so one, to identify the etiology, what caused it, and then a code from I-15, which is a specific type of hypertension. Now, most of us know, especially new coders, one of the first codes that you learn is I-10, because we use I-10 to code, and it just happens to be hypertension, and so many people have hypertension, and it's all kinds of hypertension. It could be malignant hypertension, essential hypertension, et cetera, but it cannot be a specific type of secondary hypertension because it's got its own code, and it's an E15. Okay, so in other words, you're going to have two codes. You're going to say, this isn't normal hypertension. This is secondary hypertension caused by something else. So I'm going to code for I-15 stating, this isn't an I-10 hypertension. This is an I-15 hypertension. And we need to know the etiology and the manifestation, which, again, the manifestation is the I-15. Why does the person have, why is the person in E15, the manifestation? Because of this etiology, this particular condition that turned them into that. So think of the diabetes. What caused it? Now, there can be several different things. However, with this one on your sequencing, heads up, pay attention, because it really depends why the patient's being seen. Are they being seen or admitted for the manifestation or the etiology? So when they go in, are they being treated for the secondary hypertension, or are they being treated for what caused the secondary hypertension? You're going to use both codes regardless, but they want to know which one is the reason for the patient being seen, because that's going to tell you which one's going to be the first listed code or the principal diagnosis. Okay. Pulmonary hypertension is very unique. I encourage you to go read more about pulmonary hypertension. As you know, pulmonary has to do with the lungs, and it's a unique type of hypertension. There are guidelines that surround it, and so that's why you should understand how it's different. But it is an I-27. So it's not an I-15. It's not an I-10, right? It's I-27. And it specifically is a type of heart disease. If you have secondary pulmonary hypertension, then you're going to code I-27.1 and look at I-27.2. And whenever you see that dash, that means there's more codes. Also, anytime you have any other conditions or adverse effects, whether they be from drugs or toxins or whatever, okay? And then it says, okay, by the way, the sequencing, which goes first, is really going to depend on that same section that we saw before, 1C19E, all right? Because that has to do with poisonings, toxins, and all that adverse effects. All right, so pay attention, little light reading, go look in your tabular at I-27.1 and I-27.2. Familiarize yourself with what the information says for secondary pulmonary hypertension. Very good. In addition, we have types of MIs, myocardial infarctions. There is a condition that it's called, you can have a type 1 or a type 2 MI. And I went ahead and decided to explain that a little bit more in depth. I've done, CCO has other lectures, probably in YouTube, definitely in the club, about STEMIs and non-STEMIs, as well as type 1 and type 2 MIs. So let's talk about that we have for type 1 infarctions. You're going to have I21 through 0.0 through 0.4, and then we also have I21.9, which is probably unspecified. Then when you look at type 2 is just secondary MI. Now, that doesn't mean a subsequent MI, because a subsequent MI is actually pretty common. Within the first 4 to 5 weeks after a person has an MI, they're likely to have another one. It's extremely common. And that would be called a subsequent MI, not a second MI, or not a type 2. It is a second MI, but it's called, the term that you want to use is secondary. And when you say that, then the person, the clinician, the provider knows, hey, that's probably in that window. You know, it's not an old MI, it's a subsequent MI. They had one MI, and a week later they had another one. It's pretty common, right? Type 2 is secondary. I had an MI because of something else. And what is the something else, like the diabetes that we talked about, right? It's due to either demand, ischemia, or an ischemic imbalance. And when we talk about ischemia, that is just that heart condition, the way the heart works. So it's telling you that if that happens, then you're going to use I21.A1. Go look at that code in the tabular. And that's an MI type 2 with a code for the underlying cause. So here we kind of, your manifestation is your type 2 MI. So what's the etiology, the underlying cause? It is, you know, something else. And there's lots of them. But I went ahead and pulled this definition and not footnoted, but put it in the resources where you can look more to it. It says if type 2 MI is defined as a myocardial infarction secondary to ischemia, in other words, it wouldn't happen if the patient didn't have an ischemia, due to either, one, they have an increased oxygen demand or decreased supply. So supply and demand of oxygen. Why are we getting lower oxygen? What if the person has COPD or emphysema and their oxygen level gets so low that it triggers an MI? Then the person has a type 2 MI, right? They wouldn't have had an MI if we wouldn't have had a lack of oxygen. Why do we have a lack of oxygen? They have emphysema. Okay, so it says also this category is used also for the last 5 years, yet little is known about a patient's characteristics and clinical outcomes. The reason it's stating that is because of where I got that information. It was actually a provider information about explaining some provider documentation and stuff about type 2 MIs. Okay, so again, primarily what's happening to the body, just like we know that a pancreectomy is going to turn a person into hypoinsulinemia, right? We know that. And so therefore there's codes that we have to tell the story. So if a person gets a type 2 MI, it's a secondary, then we know they've either had something that happened in the lungs that there's a problem with the oxygenation that's getting to the heart. Right? And it's not just a simple blockage, or maybe it's some type of a blockage, but it's not your regular MI. Something happened, because an MI is a blockage, whereas a heart attack or heart failure, excuse me, the heart stops beating. Right? Two different things. And we've had lectures on this too. Go look them up in the club. What's the difference between an MI and heart failure? MI, we got a blockage somewhere. Oxygen's not getting to the heart. Eventually, the heart will just stop moving. It's not getting oxygen. It just dies. Okay. It's kind of, think of a fish flopping. You catch a fish, you lay it out on the bank. Eventually, it's going to stop moving because it's not getting oxygen. It's not going to flop around anymore. That's what your heart happens. When your heart doesn't get oxygen anymore, pretty soon it's going to quit moving. Now, because of a blockage, no oxygen's getting in. However, when we have heart failure, the heart has stopped moving. Therefore, we're not getting oxygen, right? And that's when you can go in and like use those paddles. So usually, not always, there's something electrical going on with the heart, or chemical, or something's happened to the muscle that has stopped it. Okay.
I want to stop you for a second.
I think you get an understanding of it.
I want to stop you for a second before you answer questions. Can you stop your camera for a second and then just start it up again? Because your audio is not in sync with. Turn it right off and give 2 seconds and then.
Did that work? I did it. Do I need to do it again?
You did it?
Oh, that was my mic. I'm sorry. I hit the wrong icon.
No, you're fine. You're fine. That'll work. Actually, you're fine. Come back now.
Another reason why I might need to wear those glasses. Oh.
You're good.
We're not going to talk about that. Okay, so I want to just summarize a little bit. A secondary, when something is secondary, is part of the disease process, and versus etiology, manifestation, things like that. So you're going to see words like due to, right? Think of when a person has a punctured lung, then they could have a tension pneumothorax. All right. They wouldn't get a tension pneumothorax if they hadn't had a punctured lung. Then of course we have, you've heard of the secondary malignancies, right? It's a result of something else. So again, primary malignancy is the first time the person gets cancer, or at least that they found the cancer. They wouldn't get a secondary malignancy, which is a disease in and of itself, if they hadn't had the primary. So that's why secondary applies. It's not, and you can't get that confused with sequencing primary and secondary codes, right? Because some will be first listed and some will be secondary codes. No, we're talking about the disease itself being a secondary condition to something else, right? Okay, that's the slide I knew I created, and I didn't see it in the screen, and I don't know, I probably copied and pasted it, did it wrong. So now I'm ready to look at the questions over here. So if you have any other questions, you need to post them real quick so Boyd can put them over here so I can see them. Whitney says, what if it says the patient is overweight? Okay, you're talking about the BMI. Being overweight is not obesity. So in a situation like that, I would query the provider. And very seldom is the provider not going to use the word obesity unless they're worried about the patient reading the chart, and they have to not be worried. So you need to come to an understanding with the provider, have a little sit down and say, in scenarios where we have a BMI that is classified as morbidly obese, like a 55, and you write that the patient's overweight in the documentation, does that mean the person's morbidly obese? Because it doesn't say morbidly obese. And when I am coding, it doesn't translate. The code doesn't, and I'm here to translate for you. So either I have to see morbidly obese or obese, because that's what the guidelines tell me. That has to be in the documentation. Or we have to have an understanding written down in our compliance log that states that when you document overweight, that equals to obesity. And then everybody has to sign it, because if somebody comes in and audits that, they're probably going to toss that out and say, no, you can't. You can't, because obesity and being overweight is two separate things. Okay. So that's what I would do. Now, does that mean you can't ever do it? Well, if you have that conversation with the provider and they say, no, every time I say overweight, I'm saying it's obese. And the reason I'm saying that, and I don't want that documented, because I've had too many women come in and get all frantic and upset because I wrote that they were obese, and now everybody gets to see those. They go home with that, and then they're upset. So again, it has to be an understanding. The documentation has to be clear somewhere that states that. But being overweight is not the same as obesity. It's not synonymous, and it's definitely overweight is not morbid obesity. Okay, but you have to have obesity or morbid obesity documented to be able to code the BMI, or severe underweight, which also is, there's a low BMI is just as bad as obesity. Okay, so the next question. Oh, somebody. Okay, so Whitney said, would Z59.0 be appropriate if a patient is HIV patient and they have been non-compliant with their medications in office due to being homeless? Absolutely. It absolutely is. If the patient is homeless, it needs to be documented. And if it's documented, because that changes the plan of care. It's just, think of it just the same way as if a patient is elderly and they're a fall risk, frequent falls, there's codes for that, because they're just an accident waiting to happen. So again, if it's not documented that they're a fall risk or that they're homeless, then they may not be able to get assistance or help that's allowed to them. But above and beyond, we're not talking about money here. We're also talking about statistics. So how can we collect the statistics of people who have that are HIV positive and homeless that are not compliant? Is it not compliant because they don't want to take their medicine? Well, absolutely not. No one's not going to take the medicine. Is it because they can't afford the medicine? They don't have insurance? Or is it because they're homeless? They have no place to get their mail. They have no place to get XYZ. We have to remember that's something we keep statistics on. That's why we do what we do. The money and everything is just a sidebar. So the fact that we're using the Z59.0 to state that the patient is homeless isn't going to make a difference in how the provider is paid or reimbursed. It is going to make a difference in the care of the patient in the future. It's also going to make a difference on the state and the federal level for the for people who are homeless that have HIV, because they'll be able to collect it statistically. So say there's a particular state that has a higher level of homelessness, and they can even break it down to the county. And let's say that people in the South, there's more homeless people in the South than there is in the North because it's warm weather, right? It's easier to live outside. And so if people have a condition like HIV and stuff, then statistically we can see why is all of a sudden this particular county in California have an elevated levels of HIV diagnoses, HIV positive. And then you realize, hey, there's a large homeless population there, and they're connecting however you want to connect, whether it's using each other's needles, using, sleeping with each other, it doesn't matter, but it's spreading in this area. Why? Maybe, maybe is it because they're homeless, or is it because of something else? And we can track that statistically. What about prediabetes? There's a code for prediabetes. And it isn't a secondary condition. You don't have prediabetes as a secondary diabetes. So prediabetes will not fall under the E08, E09, or E13. Okay. Kathy says, I have seen a provider document type 2, but not any contributing etiology. Is it appropriate to code just the type 2 without anything else? Yes. Yeah. You may not have any etiology. Type 2 is a type of diabetes. Type 1 is a type of diabetes. Just because they're a type 2 doesn't mean they have an etiology or a manifestation. Okay, it is the etiology. It is a disease, type 2, just like type 1. But what we know is type 1 diabetes and type 2 diabetes are two separate types of diabetes. The body reacts differently. So type 1 diabetes, the patient cannot produce insulin, and they require insulin. They will die without insulin injections. Okay, no, oral medication doesn't work with them because insulin can't go into the stomach. The stomach counters out. It destroys insulin, so it can't hit the gastric juices. So the medication that controls sugar, the oral medication, is not insulin. It's something else, right? But type 1 diabetics have to have insulin no matter what. They were born that way. It's a genetic disorder, and they're congenital, and they will always be a type 1 diabetic. Nothing is going to take that away. Okay, they're for whatever reason, usually the pancreas didn't develop correctly. Now, type 2 diabetes can be for a lot of different reasons. Maybe it's genetic, maybe it's congenital. You can be born with type 2 diabetes and not be type 1 diabetic. It could be something else in the body that did it, but then it's a secondary. But again, it could just be that when you turn 40, you quit exercising, you got fat, and you turned into a diabetic. It could be genetic in that you're predisposed to it. So again, lots of things can cause type 2 diabetes, but just because it's type 2, it's not secondary diabetes. So type 2 diabetes is not secondary diabetes. You have type 1, you have type 2, and you have secondary diabetes. Okay, actually you have type 1.5 too, but that's another story, which we have done a lecture on. Very good. We are having a terrible time with providers documenting obesity and BMI BMI correctly. So in other words, you just need to have a little cheat sheet, send out a little flyer to your providers and say update on obesity and BMI. Say, to translate this properly for you, when a person has an elevated BMI, we need documentation of obesity or morbid obesity to be able to capture the BMI. Now, if a doctor states that a person is obese, but the BMI is not an obesity BMI, it's not up to you to say that's wrong. Okay, so to be obese, there is a range that tells you if you are I can't remember what it is. I want to say it's a 45, but it might be like 42, 43. So let's say it's 45 to 50 is obesity. 50 on up is morbid obesity. So if the patient is documented as obese, but they have a BMI of 55, you cannot code it as morbid obesity because the doctor said obesity. Now, if you want to code it as a morbid obesity, then you query the provider and get permission to do that and everything. But all you have to do is make a little cheat sheet, send it out as a friendly little reminder. It's keywords that you tell these providers. That's all they want, keywords. What do you want me to do? And then you say, okay, every time you have a patient that's obese, I need documentation of obesity and a BMI range of X to Y. And then if they're morbidly obese, I need a BMI range from Y to Z. And give them that little cheat sheet and then a bag of chocolate. At least that's what I like to say. Is that it? Any other questions coming through? I don't think so.
That is all.
All right, guys. So this was really, really good stuff. I know that you probably have lots of questions. If you want us to expand on any of this, make sure that you go into the CCO club. Here's the resources, the links that I used, and feel free to ask your questions in the CCO club. If you're not a member of the CCO club, you don't have access to that, you can join the free forum, but our CCO club gets access to these recordings and everything. This is going to come down. So you're getting to watch it live stream, but it's going down. You might get clips and little bits and pieces that Boyd gets creative with, but it's just to whet your appetite. The CCO club is where people get to have access to this. They also get the slide deck, and they can go in there and ask questions about this, and we can expand our topics. Maybe you think of something else, or a scenario pops up in your office about a type of secondary diabetes or whatever, and we're there to answer those questions or find resources so that you can better explain it to the provider or whatever you need to do. It's a lot of fun in there. So again, just go to cco.us/club if you're interested in that. And otherwise, make sure you like and subscribe. If you're watching us on YouTube and Facebook, make sure you hit the little bell in YouTube, and then you'll know whenever we have a live video coming up, because we do these very often during the week. But again, they're exclusive, so they come down right away. All right. Thanks, guys. Have a great rest of your day.